So what
That's not my
happened?
experience.
What happened?
It just, you know, it's not having any money. It's a different microphone.
Oh,
It's- It all started with Orton running into the cave with a burning stick. And ever since, technology has been a challenge.
I like your mask. It's great. It's got a little pouch out there in front. What I'm thinking is, if you extend it, make it a little trunk.
You get a mask, you know. And I really like it.
Yeah, I like the color.
I don't, yeah, it's very simple.
I just figured it was camo.
Oh, that's what I tell people. All of this fascination. You know, the title, that's just.
You have children as well. How old are they?
10 or 12.
So yeah, I mean, I figured maybe they recommended you get a camouflage mask.
Well, especially with my back. They're always, my daughter loves like, all of her stuff that's music.
Test, 1, 2, 3.
Not pink.
Yes. So working on it.
All right, let me post this new stream
She has
and then
cities,
we can go.
she has cities. Rural.
I said, yeah, and I wait, what was it? 7 months?
She's actually born in Sacramento.
Sacramento.
Moved there.
Jeff, what's CFR?
Jeff, when you get the go-ahead from Catherine,
Ah,
I'm sorry.
when you get the go-ahead from Catherine, why, go ahead with your,
okay, we're good now.
okay, if she said you're good.
Okay. Sorry for the delay.
Do you want to call me?
Well, we'll return to our meeting, and Jeff Lee has the floor.
Thank you, sir. So the quick stats on what's going on with COVID-19. We are over 20,000 cases as of this week, and about 5,000 of those are still active, which means they're infected and infectious to others in the community. Hospitalized today is just under 1,000. The median age is 73 years, but we've had pediatrics under 12 months of age in there. We've got a number of pediatric cases in the hospital right now as it is. Deaths to date have been 236. That's slightly over 1% case fatality rate. And the caveat on that is we don't know all the cases out there. Not everybody who has been infected has been identified or tested. So this is an estimated case fatality ratio based on the number of known cases at this point. Median age for death is 81, but we did have a person under 50, that 37-year-old, die here real recently. And we think we got another individual under 50 in today as part of the death certificates. Current hospital status as of this morning, they were at 103% of maximum capacity at Kootenai Health. This is of concern because Kootenai Health is the catchment hospital for the critical access hospitals in the other 4 counties. And what this means is they either don't have the staff or they don't have the beds. And this was specifically pointing at med-surg, not necessarily COVID, but the med-surg portion of the hospital. So if somebody has a car accident today and they need to go to surgery, they might have to be shipped somewhere else if there's no bed for them to go to after surgery. Same for heart attacks, strokes, that kind of thing. So our hospital is still stressed out and in the red zone. Next slide, please. Thank you. this is the current epidemic curve. As you can see, we peaked back in the middle of December and have been coming down. The number of cases we see on a daily basis has been trending downward, which is good news. As those cases trend down, we'll see fewer hospitalizations. The hospitalization rate of cases has been right around 5% throughout the pandemic. And so we are, and you will see from the slide showing it, hospitalizations are moving down as well. So this is good news at this point. But we're still seeing right around 100 cases per day on average. So we're not out of the woods just yet. Next slide, please. So one of the tools that we use to determine where we are at as a health district for the pandemic is by looking at the average daily incidence rate. It's a 7-day average, and each one of the points along here is a 7-day average as of that date. We look at a 14-day spread of these averages to be able to look at trends and make some inferences from that. As you can see, all of the 7-day averages are trending down. In fact, we've got 2 counties definitely back into orange, Shoshone and Benoit, and Boundary County is right at the threshold, ready to cross over back into orange. Kootenai County and Bonner County are still well into the significant community spread area, but they are also trending down. Next, please. This is a daily look at positivity rates. So positivity rate is taking the proportion of all tests conducted that are positive. So even though we may have different number of tests, even from one day to the next, we can look at that proportion and compare them directly as long as it's in that format. And the significant threshold for positivity is at 20%. And we have been above 20% most of November, December, and the earlier part of this month, but we are now trending down. As you can see, it's a fairly steep decrease. And we're now below 20% and into the orange, or moderate community transmission for COVID-19. When it reaches 8%, then it will be going into the yellow or minimal transmission, community transmission. And the numbers from the state also agree with this. We're looking specifically at the testing done through Kootenai Health. This includes all the pre-procedural as well. The number from the state is right in line with our positivity here today. The problem with the state number is there's about a week delay in us getting them. So it was actually lower a week ago than we were. Next slide, please. So hospital admits, as you can see, they've been busy. But if you look at the tail end over on the right-hand side, it's coming down as well. Again, as I've indicated, about 5% of our cases will end up in the hospital. So as that case count comes down, we're seeing hospitalizations come down. And in fact, and I think I mentioned this, the hospital capacity at Kootenai is more a function of the med-surg beds and not because of COVID-19 admits. Next slide, please. And then death rates, or death numbers. We are seeing more deaths occurring at this point in time, but that's what's happening nationwide. And there is a sequence from the time we see the testing numbers and we get the intake to the time somebody is going to be hospitalized is roughly 5 to 7 days or more. And then from hospitalization to death could be up to another week before we see that. So there's a lag. And so we should be seeing these fatality rate numbers coming down. Next slide, please. So, per request, I just wanted to do a little bit of a comparison with, between COVID and what's going on with flu right now, locally and nationwide. So right now, flu at the national level has a positivity rate of 0.08%. Typically around this time, that would be well above 10%, probably 20, 30%.
We're getting some feedback here.
So the number 14.7% of deaths due to pneumonia, influenza, and COVID. This is the first year that COVID has been put together with pneumonia and influenza. For decades now, for flu surveillance, the CDC, the WHO, others around the world put pneumonia and influenza together when they're looking at mortality during flu season. This year we've added COVID-19, so it has a new acronym PIC. And as you'll see on the next slide, we're not quite there yet, sorry.
Sorry.
No, that's okay. No, go ahead and go to the next slide. I just was anticipating a different slide. We'll go over quickly the flu for local. We're at 0.77%, and we'll also see a comparison of where we are today with flu in our district and looking at the three previous seasons. We've had 12 whole cases of influenza reported through our Sentinel sites. We typically have had hundreds by this point in the calendar. We've had no hospitalizations reported today from our Sentinel hospital. There's been one death reported in the 5 northern counties, and I believe there are only 5 total for the whole state at this point. Yeah, well, I wrote it right down there. Next slide, please. So this is a slide directly from the CDC. Now, if you look at the wavy pattern there, the black wavy pattern, that's 2 lines. The lower of the waves is what's called the baseline. And you can see that that is fluctuating over time throughout the year. Along the left-hand index, that's percentage of all deaths. So the percentage of all deaths that are caused by, in the past, where it's just a red line there, is pneumonia and influenza, and it's seasonal. The epidemic threshold is the next line up. When the deaths exceed that threshold, it's of concern. So as you can see, back in 2017, 2018, 2016, 2017, the very first group there, that there were some excess deaths related to influenza, some excess deaths above the epidemic line. In 2017, 2018, which was the worst year I can remember, and I've been doing this for a long time, we had a lot of deaths. Comparatively speaking, a lot of deaths for influenza in Idaho and in District 1. And you can see that the excess death is indicated well above the epidemic threshold. Then not so bad in 2018, 2019. But moving into 2019-2020 flu season, what we see here is an extreme increase in the number of deaths. And this is the time period that we introduced COVID-19 as part of this constellation of pneumonia, influenza deaths, and the contribution of that to overall death rates in the United States. So you can see along the right-hand axis, that's the number of deaths. The red extends up to 20,000 in 3 waves there in the 2020 period. And the blue shading, that's the amount contributed by COVID-19. So it's not showing, we don't have an independent influenza. Flu and pneumonia and COVID are the red lines now. But as you can see, predominantly, most of it is caused, 68% of it basically is caused by COVID-19. Next slide, please. This is another interesting graph. This is pediatric deaths. And as you can see, in previous years, we've had significant numbers of pediatric deaths, unfortunately, related to influenza, up to and including last season, the 2019-2020 season. We have one lone square in the 2020-2021 season. That is the only pediatric death that has occurred to date in this season from influenza or pneumonia. That's it.
That's for our district.
No, sir, that's the United States.
Wow.
Okay. Next slide, please. This is a 4-year graphic. It's a little squiggly when you try and put more than 2 or 3 in there. But basically, if you look at 2017, 2018, it's purple. If you look at the purple line, and I think I can highlight that. There we go. And this doesn't show up on that screen. Okay, that's
You want
perfect.
this? No, this one.
No, that's okay. So the purple line, as you can see, it peaked up there around 35%. That's positivity rate. It actually passed the 10% positivity rate threshold in late October, early November of 2017, and expanded through week 16 of 2018. So it was the longest epidemic of influenza for quite some time, and had the largest community spread and the most deaths. In 2018, 2019, that's the green. You can see it passed the threshold and was considered epidemic in our area several weeks after, later than the previous year. It was a much shorter season. It reached fairly high, though, towards the end before it came back down and ended. And then the blue line, 2019, 2020, is kind of incomplete because around the time as this was trending back down and it had gone below the epidemic threshold for our local region, we were up to our neck in COVID-19. And influenza surveillance at that point had to take a back seat. The red line is this season, now, here. Can you see it down there at the bottom? Lost almost in the week numbers. Yep, that's it. That's our flu season so far. 12 whole cases, 1 death. So, and I've put the references up here, and you certainly can have the slide deck. The COVID mitigation, social distancing. Oh, I'll go back.
Sorry, I'm trying to find our people.
Social distancing, staying home when sick, washing hands, wearing masks, have decreased flu transmission from greater than 20% down to 2.3%, as estimated by nope, I need to go back. Thanks. And this was also the same pattern and findings from the Southern Hemisphere.
We need to recess again. We're having a problem with Zoom with our board members. I'm gonna
Lost-
underline your thing
lost
there.
Zoom. All right,
Oh, that was-
time out.
That's the problem.
There's a whole lot of misinformation, and statistics. You can tell a lot of things. You can twist them and turn them to show whatever you want to show. What's the overall depth? Is it within the range?
It's exactly the same.
Year to year, are we still within the range by demographics?
Cancer.
Everything I'm saying, we are. Numbers are everybody. What's happening to our businesses? What's happening to our country? Yeah. Is it worth it?
No, it's not to me. No. So I'm gonna do a video with Bill Riddle, scientific method. I'll forward it to you.
Is that the guy peeing on the tree?
No.
I like that scientific.
That's good.
Scientific evaluation, can you say?
No, this is, he's talking about how the scientific method has been pretty much abandoned in this entire discussion. Wow. So is Commissioner Brooks, part of the audience today?
Some are us invited to come watch. Is everybody there? Karen, the other lady, is medical, something
She
related.
was just hired recently.
There's Michelle.
Michelle is our HR person. Okay, so we have. Yeah.
All right, we're back to order again, and we're still listening to Jeff Lee. Jeff, you still have the floor.
Thank you, sir. Are there any questions from the data presented today?
Okay.
Mr. Chairman?
Yes.
I do have a question for Jeff. Obviously, in statistics, you have a range that is normal year in and year out. As far as total deaths in the United States, outside of PIC, et cetera, do you know whether our total deaths has increased or remained within the range?
Well, according to that, the proportion represented by the pneumonia, influenza, and COVID-19 constellation has increased the cause of death. It's been a larger proportion of the deaths. I don't know what the entire,
The total death numbers is what I'm talking about.
do you know what they are, sir?
My research shows it has remained within the range has not jumped up considerably.
Where's that
So-
research from, sir? Because Dr.
That's from the
Khan,
Center Disease Control.
Dr. Khan has
CDC.
presented here that it has a significant increase to overall
And
deaths.
that's not my understanding, so.
Um,
As far as our district, have the death numbers drastically increased among the 70 to 90-year-olds?
I don't track mortality, that's at
That would
the
be
state level.
interesting, that would be interesting to see.
We can request that through the Bureau of Communicable Disease, but that would have to come from the Division of Vital Statistics. And they should probably do have something on their website.
Is there a correlation between the ups and downs on the graph and our implementation of the mask mandate?
Can you be more specific about ups and downs?
Is there a correlation between the increase in COVID cases, hospital rates, death rates from the time, the end of November, when we passed the mask mandate? Is there a correlation?
That's a good question, and I would have to answer that, no, there's not. Overall, the numbers were going up during that time peak and actually peaking. But
Both
we don't
statewide,
have,
regional-wide, and nationwide.
yes, but we don't have.
Going up and down, very same, despite many areas having mask mandates in place and limits on the size of a group. Despite that, versus other locations where there were no limitations on the size, the numbers.
That's not entirely true, sir. I did present that at the last board meeting. We showed that a state with a mask mandate, please let me finish. A state with a mask mandate had 1/3 per capita, 1/3 the cases as Idaho. That's Washington State. And Spokane County, while not as low as the rest of Washington, because a lot of population comes over here because there is no mask mandate that they have to adhere to. There's no enforcement of it. Also was lower per capita than Kootenai County. So yes, we have demonstrated that in areas where a mask mandate is followed and is enforced, that the per capita rate of infection is low. We don't have the ability at this point to go out and do field studies of the rate of compliance with masks. You know, there's a portion of the population that is happy to wear a mask, and there's a portion of the population that doesn't like masks. You know, and that's represented in this room right now. So we don't have that data to use. I'm not going to make guesses or assumptions. A lot of people are doing that. They're making guesses and assumptions. They're drawing inferences from incomplete data, and we try not to do that. So the data that we have here is based on information that we have collected.
I would ask you to get the total death numbers in the United States from the Centers of Disease Control, if you want to use that as your source, so that we could see if they're still within the range.
You bet.
Thank you.
All right, question, Dr. McLanders, you have the floor.
Yeah, but at one line,
Dr. McLanders, could you speak a little louder?
can you hear me now?
Barely.
I'm speaking as loud as I can. I'm not sure what to do with that. Can you hear me, Mike, better?
All right. We need to do something about Dr. McLanders. We are unable to hear you. Is there some way we can increase the audio?
I will give it a try. Hang on a second. Lucy may have to come back in, but hang on just a second.
Dr. McClanders, can you get closer somehow to the microphone you're using?
I am very close to it.
That's better.
That better? Okay. So can you hear me now?
Yes, sir.
Right? You can hear me okay as well? I'm gonna try this, let me know if you can't hear me. I'm on line CDC reports from March 15, 2020 till January 2, 2021. 18% higher than normal death rate. Since March, documented 425,000 more Americans have died than would have died in a normal year. So that's my report, 18% increased excess death rate. And that has been reported ongoing over the recent months. This is reported, as I mentioned, January 2nd. Can you hear me, Jeff?
Yes, sir.
And what's the source, Dr. McClanders, of your information?
You're on mute, Dr. McClanders.
The CDC.
Okay, because that's not the information I received. Thank you.
Mr. Chairman?
All right, Jeff, did you have a response to Dr. McClanders?
No, thank you very much
Oh,
for
okay.
having that available.
Dr. Banks, I see your hand up.
Yeah, just briefly, I've looked at the CDC numbers, and for the state of Idaho, there's no increase in deaths over the previous years. And the same thing is nationwide. Now, what's interesting is that Dr. Brand at Johns Hopkins published a study where she analyzed the CDC numbers and found that there was no increase in deaths in the United States over this time period, but there was a vast disparity in the causes of deaths. In previous years, heart disease was the #1 cause of death in the United States, and the CDC statistics for the year 2020 show that heart disease fell to #8 as a cause of death. Influenza, which formerly was the leading respiratory illness, has fallen to 2% of previous diagnoses. It's suspicious because the total deaths are the same. So it makes one wonder whether causes of death have simply been changed on the charts, and the actual deaths, for example, someone dying of heart disease because they're COVID positive with the PCR test, they're counted as a COVID death rather than as a heart disease death. I think there's a reasonable suspicion that that's true, and we need to take that into account in any decisions that we make, that the statistics are statistics, as it were, and the actual numbers of deaths really have not changed at all in Idaho or nationally.
Hi, may I share a screen with you guys directly from the CDC on this excess death
Karen, yeah.
question?
My virologist.
Mr. Chairman,
Yes.
this is Dr. Karen Yao. She is our, another of our epidemiologists, microbiologist, and she's requesting if she could share a screen.
All right, Karen, you have the floor. You may speak.
Great, thank you. Okay, so this is a page that's directly from the MMWR report from the CDC that talks about excess death that's associated with COVID-19 by age, race, and ethnicity in the United States between January 26th to October 3rd of 2020. And basically in their summary is this chart that from late January to early October 2020, the US had 299,000 more deaths than typical numbers during the same period in previous years, which is qualifies as excess deaths, is more deaths associated with that, and at least 2 out of 3 of those excess deaths are associated with COVID-19. And that there's also a race disparity because the largest percent increase were among people who were Hispanic or Latino or adults that are age 25 to 44 years old. So here's the direct report from the CDC. And I'm not sure what, if you could, Dr. Banks, if you could share the reference that you had just mentioned with us of the other Hopkins study, that would really be very helpful.
All right, thank you. Is that the end of what you had to share with us, Karen?
Yes, that's all.
All right. Any comment, questions, or response? Jeff is, still has the floor and is dealing with questions.
Are there any other questions? Okay, thank you very much.
Okay, thank you, Jeff. That would conclude your report. And then we're
Mr.
going
Chairman?
to- Yes,
Mr. Chairman,
Dr. McLanders?
I'm just testing my mic. Can you hear me now?
Yes, much better.
Okay, thank you.
All right. Don Duffy, are you within, there he comes, the real. You have the floor, Don, giving us your report on the immunization distribution.
Well, thank you, Mr. Chairman and members of the board. I appreciate the chance to go over how we're doing on vaccine distribution. So I'm going to give you a couple of numbers here. I'm sure you'll have some questions, which I look forward to answering for you as well. As of Tuesday night, Panhandle Health District has been the conduit of distributing 13,435 first doses of the vaccine, and that's a mixture between the Moderna and the Pfizer. We've also distributed 3,260 second doses of the same product. Just to give you a little understanding here, the state receives roughly 20,000 doses a week. And then from there, that's distributed to the 7 health districts. Over the last 3 weeks, we have averaged 2,750 doses per week that we've gotten from the state. You know, of that 13,435, Panhandle Health District has administered 30% of those doses, or 4,125. The rest has been our other 15 partners that we have, enrolled providers that are administering that vaccine, which is very helpful, and they're scattered all over the 5 counties here in Idaho, or excuse me, in District 1. We have 2 responsibilities as a health district. One, we are essentially the gatekeeper for these. They come to us and then we distribute. We also want to make it very clear that we're evenly distributing these vaccines across our 5 counties based on population, and that's what we're doing currently. And so to give you some idea, if we were to receive around 2,700 doses, that would break down to 1,780 to Kootenai, 500 to Bonner, 140 to Boundary, and 140 to Shoshone, and then 110 to Benewah County. Where we have moved through our phases, as the governor has asked us to do. We moved through our healthcare personnel, and then through our schools, teachers and staff, critical infrastructure, first responders. And we have a few of those that still are trickling through the process. But now comes the big task, and that starts on Monday, and that's distributing the vaccine to our 65 years old and older. that is a challenge, and we could not do this without our many partners throughout the health district. If you think about that just for a moment, again, with those that are in long-term care facilities, and that would be skilled nursing facilities or assisted living facilities, there is a federal pharmacy program in which Walgreens is taking care of that. They are going in and vaccinating patients and staff, which we are most grateful for. But you take out that population, there still remains over 51,000 individuals that are in that age group of 65 and older. If we estimate, look at a percentage of how many of those choose to be vaccinated, by the current vaccine flow that we're getting, around that 2,700, it'll take us 7 to 9 weeks to get through that population. And so again, it'll take a while. And then we'll move into our essential workers, like our grocery and manufacturing. And then after that will be the general public that will be open to be vaccinated. We did get some good news this morning, however. Each week we get a notice from the state of what our allotment will be the following week. And as I mentioned, that's been around 2,700 for the last 3 weeks. The allotment that I saw early this morning was 3,850 doses. I immediately contacted the state director of vaccinations, who we get the letter from, and she indicated that that would be consistent, that we would be getting around 3,850 to 4,000 doses a week. That will significantly help our ability to get this vaccine out quicker. Clearly, I want to also make it clear that we do not hold large amounts of vaccine in inventory. Our goal, and we've been able to live up to this, is the vaccine we get 1 week are in people's arms the next week, through work that PhD does, as well as our excellent partners out there. On that, I have put together all of these partners. There is 11 of us that are regularly administering the vaccine. We have others that need it sporadically, which of course we honor. And we meet once or twice a week. And that group makes the decision on 2 things primarily: how the vaccine will be distributed, and ensuring that we're following the governor's plan on the phased approach of vaccination. That has been a tremendous help in making this a group effort. This is not a sole decision made by the health district. It is the health district and our many partners that are making that decision. So, for example, we're meeting again tonight, and we have 2 goals: to talk about what our messaging looks like for the 65 and older. We want to all be on the same page in what we're telling the public. There's been, honestly, a lot of confusion with that. And secondly, how we are going to allot these additional doses that we've received. And we'll have that discussion. So we're very hopeful that tomorrow you will see on Panhandle Health District's website these various locations throughout the 5 counties where people can go to become vaccinated. But as you can imagine, all 51,000 are going to want to be vaccinated next week. And so we're just encouraging the public to be patient with this extra allotment. And if it continues, we'll be able to be done with this in 5 weeks. So we hope that that continues. But I know it's been frustrating to the public. It's been frustrating to us. And but we think we're in a good plan now. We've moved nicely through the phases, as I mentioned, and now comes a challenge for us. But our partners are in place. The only thing that would change the dynamic is if we got more vaccine. So that's essentially my update of where we're headed with this, what we've done so far, and where we're going. Are there some questions that I could answer for you?
Mr. Chairman.
Glenn, did I see somebody up here? Dr. McClandris will take your question now, and then Glenn.
More just to make a comment, I'm on this committee representing the board, and watching Don do his work. I want to compliment you, Don. You are a fantastic leader in a group. Everybody in that group has their own population that they're caring about, and I want to just compliment you on how well you're doing in managing a big challenge, the ethics of how to distribute a limited supply are certainly going much more smoothly because you're managing it so well. So thank you very much.
Appreciate that. Thank you.
All right, Glenn?
Thank you, Mr. Chairman. Don, my question is out of curiosity. The vaccine we're receiving, from which manufacturer? Is it the 90% effective or the 95% effective?
We are getting it from both manufacturers, and actually, we don't know until we get that letter what it's going to be. It could be 950 of Moderna and 2,000 of Pfizer, and then it could flip the following week, which is a little bit of a challenge because, as you know, there's some care and monitor of that that's different. So that's another great reason that we meet a couple of times a week with this group. We can let them know so that'll help them. When they know what's coming, it determines what they ask for their allotment.
So in the distribution, those that have received the first dose, do they then have priority to receive their second dose over those who have not yet received it?
What happens is what I have spoken about in numbers, when I talk about the 33,850, I'm only speaking of the first dose. We automatically receive the second dose. That comes automatically. So, either 3 weeks or 4 weeks later, depending upon what manufacturer it is. So that is guaranteed that those will receive it. Most of our providers are using a scheduling system that when they come in for their first dose, they are scheduled that day for their second dose, and they are guaranteed to come in for that. So you don't need to worry about, is there going to be enough around to get my second dose? So far, that's been guaranteed.
It's good planning. Thanks for the clarification.
Okay, Laura?
Thank you, Mr. Chairman. Just on the point of clarification, the phase 3 clinical trials of both the Pfizer and Moderna, 2 weeks after the second dose, well, they're both pretty comparable for the clinical trials in providing immunity in the 94, 95 percentile versus the 90.
Okay, any other questions?
Just one, Mr. Chairman.
Yes.
Yeah, Don, do you have any evidence that this actually prevents COVID infection or a different result on a PCR test?
I do not. We can only go back to the research that's been done. And also, people have asked me, are our numbers changing because of the vaccine? We've only got about roughly 2,000 individuals that have received both doses and waited the 2 weeks after they got it. So we don't have enough to know what a long-term effect it's having in our community. So we're relying on the research that's been done in the past, but to specifically ask your question, I haven't done research on that.
Yeah, my understanding, when they say it's 90% effective, what they mean is that 90% of the time, 50% of the people that were injected showed a rise in an antibody type within their test period. So 90% of the time, it's 50% effective in raising an antibody within 2 weeks or whatever it is. But there was no testing, as near as I could tell, to find out whether it prevented infection or prevented a change in a test or anything like that.
Gotcha.
Mr. Chairman?
Yes, Laura?
It looks like Dr. Yao might have some information on that, if the board would be interested in hearing from our virologist.
Yeah, I actually have a slide that explains how the 95% efficacy was calculated. Let me pull that up and I can share that screen with you guys.
Are you okay with that, Mr. Chairman?
Yes.
Okay, give me a minute to bring that up.
All right, go ahead. Do you have anything else, Karen?
Yeah, she's pulling up the slide.
Oh, okay.
So here's actually an epidemiology slide that I made for Jeff, because he's our lead epidemiologist. But this explains where we got the 95% efficacy numbers from. We actually got it from clinical trials that were done to study the efficacy and safety of the vaccines. So basically what they did was they gave the vaccines to participants, randomized these participants, compare them to placebo groups. And after at least two weeks after the second dose, they start following the participants and did comparison to see how many people who've been vaccinated and got COVID and how many people who were in the unvaccinated placebo groups got COVID. So here's an example from the Pfizer trial that show that in the group, out of the 22,000 people that were vaccinated, only 8 people came down with COVID when they followed these participants in the study. But 162 people that were in the placebo group actually came down with COVID when they analyzed the result. And so the 95% efficacy actually just shows the relative reduction in risk of getting COVID. So we do know that from the clinical trials, but what we don't know is whether the vaccines will prevent transmission. So for asymptomatic people, whether you can still continue to transmit the virus without symptoms, but we do know from the trial that it will prevent people from getting COVID after vaccination to a 95% efficacy rate. Does that answer your question?
Thank you. Any other questions? If there are no other questions, Dawn, thank you for that report and all those numbers that you're keeping track of.
Mr. Chairman, I did have one other question.
Oh, I'm sorry.
The tracking of the vaccinations, is there a nationwide database this goes into so that when I want to fly to New York City, I can show that I have indeed been vaccinated and they'll let me on board?
Well, I have a couple of answers to that, if I may, Mr. Chairman. We have Commissioner or Board Member Bailey. When you go in for your vaccine, it goes into a system, which software system called PrepMod. And once it gets into that system, your demographics and that you got the vaccine, it then goes into a system called IRIS, which keeps all of that reported for you. So that is one place where this information would be available. If you go for your vaccine, you will also receive a card that they will note on there which vaccine you received, the date that you received, and then you got your first and your second dose. If I were to be traveling, I would take that card with me. But it is true, there is an electronic record of that that's found in a state system, IRIS. I don't know how accessible that is around the country, which is why I would suggest carrying your vaccination card with you that will be given when you receive your vaccine.
Thank you.
Yeah.
Anything else?
Thank you, Mr. Chairman.
Glenn, I thought I had my card with me and I could have shown it to you, but it's under safe care. My wife is keeping track of it.
Good.
I lose things. When we adopted the order for masks, I think it was back in November, we committed that we would bring this up on every monthly agenda meeting that we had. And so we are to that point today. Item number 6 on the agenda, the mask mandate discussion. So I'm going to open this up for discussion again at this time. I see a hand, Dr. McLanders. You have the floor.
Thank you, Mr. Chairman. Can you hear me okay?
Yes, you can.
Thank you very much. I would start to welcome to my fellow Board of Trustee members. We're here as a Board of Trustees of our public health department, nominated by a majority of the 3 respective county commissioners of our county, and then elected by a majority of the 15 county commissioners, which are representing the 5 counties of our District 1. We each bring skills and knowledge to these meetings. Yet actually sitting here, we're not actually active county commissioners. We're not previous county commissioners. We're not active or past engineers or chemists or businessmen or businesswomen or nurses or doctors. We're actually public health trustees. And today, regarding this mask question, our job is to base our decisions on how to best protect the people who live in our district number 1. These people, by the way, they're our neighbors and our friends and our parents and our kids. As of about 3 hours ago, Johns Hopkins COVID Resource Center reports in the past 1 year there have been 431,129 deaths in the U.S. and 2,183,169 deaths worldwide. In the first 1 year ago, when we first started counting this in the U.S., the first 25,000 Americans died over 44 days. The most recent set of 25,000 Americans that died in the past 7 days, that's 6 times the rate from 1 year ago. Now, in the midst of this, we are inundated, actually flooded with nonsense. The nonsense that this is no more than the flu, and the nonsense that maybe actually there's actually no coronavirus COVID-19 around that's even causing all this trouble. Happy to report, but sorry to report to that nonsense is that we know better. There have been multiple studies showing by electron microscopy this virus particle. We've measured it. We've identified its RNA genetic sequencing. We've looked at the tissue damage in people who died and people who are alive in live biopsies. We see lung damage that causes hypoxia and death. We've seen lung damage that doesn't cause death, but causes pulmonary fibrosis. We're seeing multiple patients down the road who are having long-term effects, more to come. The recent heart studies show microscopic myocardial or heart muscle injury among normal, otherwise healthy 40 and 50 and 60-year-olds. We're seeing among children multi-system inflammatory syndrome in childhood. We've had patients in our own hospital with this condition who are younger than age 21. Now, another piece of nonsense is that wearing masks is of no benefit. There are multiple studies in the nation and multiple studies internationally showing at least a 50 or 70% reduction in disease communicability when communities wear masks. I'm not talking about an individual, I'm talking about communities. When more than 50 or 60 or 70% of communities wear masks, the incidence of this condition is markedly less. As you may have read in the UK, especially around London, there's new cases. Recently, the British Broadcasting System quoted a British citizen, which I want to read. Very interesting to me, something to think about. This is the quote. "These people who refuse to wear a mask who refuse to avoid gatherings, pubs, restaurants where people are close to each other, whether inside or outside. These people who are ignoring the reality, these people have blood on their hands. People have died. More people will die. So I'm thinking that the self-centered, myopic vision, which focuses on personal rights and freedoms, totally misses the big picture here. Our epidemiology, our research, our medical experts, right now warn of an ever-increasing risk in the near future. In the UK, we have now variants called N501Y. From Brazil, we have BP1. We see variants which are probably impacting the effectiveness of this new vaccine. We don't yet know if the vaccine efforts will be effective in the long run. It's going to take months. So this is not a time to back away. This is the time to step forward, to rise to work, to protect each other physically and emotionally and economically. This mask mandate recognizes the importance of this issue, and it sends a message. It's a message to our neighbors, both in our own state, our own counties, but also a message to across the state line to Washington that these people are doing business here. They're coming to our stores, they're going to our restaurants, our schools. And the message is that we mean it. That we want to protect our people. As trustees, we need to stand up and do the right thing. And I believe that we should not, and honestly, we really cannot base our decision upon the personal opinions and thusly develop action plans of our law enforcement leadership. And so therefore, Mr. Chairman, I move that the Panhandle Health District renew the mask mandate, which is currently in effect, and that we review this next in 3 months at our April board meeting. Thanks, Mr. Chairman.
You've heard the motion. Is there a second to the motion of Dr. McLandris?
I'll second the motion, Chairman.
I hear a second from Jay Nelson. All right, we have a motion on the floor with a second, and we are open for discussion.
Mr. Chairman.
Yes.
The so-called facts that Dr. McLandris cites are just opinion. I have read the papers, which I'm pretty sure he has not, where the isolation, and I use that term in quotes, of the virus is discussed, and I could find no place where the virus had been isolated. As far as I'm concerned, the actual structure of the virus, pictures of it do not exist. There is an imputed structure which came from fragments of RNA from a particular patient, which has been used as the basis for some of the tests. But as far as I'm concerned, the evidence is, while voluminous, is of poor quality. Number two, we've had an ongoing experiment going on worldwide with masks versus no masks, depending upon which jurisdiction one lives, where one lives. And there's no significant difference between areas with mask mandates and areas without mask mandates. One would expect to see a huge difference if in fact
masks were effective. And if there's just a minor difference, then the imposition of a government mandate on the public at large does not make any sense. And in fact, the evidence is that there is no significant difference between masked mandate areas and non-mandated areas. And for that reason, the evidence just doesn't support the whole concept. The same goes for lockdowns, which have occurred in some areas and have been ineffective versus areas without lockdowns. So the whole idea that we're bad people if we don't vote for a mask mandate is just silly. You know, it's fear mongering, and it isn't sound scientifically. It's not sound medically. It's just without evidentiary support. For that reason, I'm opposed to a mask mandate. I was opposed to it from the beginning for those reasons, and I'm still opposed to it. And I would hope that people could think about that when they make whatever decision they choose to make.
All right. Further discussion?
Mr. Chairman, I do have comment.
Glenn?
It's Glenn Bailey from Bonner County. I agree with Alan that I'm hearing a lot of scare tactic, fear mongering regarding the use of masks and whether they're effective or not. I do not see the data to support the level of effectiveness up or down. I see a lot of businesses suffering because of the restrictions that have been imposed at the state level. And I see a lot of people, ignoring the mask mandate. What is the effectiveness of our saying you will wear a piece of cloth over your face? I see people wearing a mask that could not provide any protection against the very small virus. I see even those people who are getting the virus, if they are younger than 60 years of age, it is very low threat as far as mortality. For those younger than 18, it's practically zero deaths within our area and nationwide. From there up to age 30, the same. There's very few, and those people are in social clubs, going to school, doing a lot of things, but I see that their lives are being impacted as well by these mandates and these restrictions. I do not see that the cost in lives or the cost in businesses is worth a mandate. I would continue to argue that we can tell people a mask may help, social distancing will help, washing your hands will help. These are all advisory things that I think can be useful, but of limited use. I think that the threat of death by COVID is being manipulated, maximized for political purposes and not based on the science and not based on what we need to do in our health district. And that's my comments.
Thank you. Any other discussion? We are open for discussion on this motion.
Chairman, can I just offer a few thoughts?
Yes. Jay Nelson, you have the floor.
Thank you. Gentlemen, Mr. Lee's presentation is concerning. We still remain in the thick of this pandemic. And now we're seeing variants that are potentially more aggressive than the initial coronavirus that has devastated this country and devastated our lives. These new variants are more contagious that are coming out of Britain, South Africa, and Brazil, potentially 50% more contagious. In fact, the UK variant, as my understanding, has already been detected in the United States in at least a couple dozen states. And then there's a homegrown variant in the state of California that's also believed to be more contagious. And so I don't think this is the time when we let down our guard. In fact, I think we need to be doubling down. We need to stop these variants from becoming a predominant strain. And again, as we're promoting and supplying these vaccinations, those offer the best tool to avoid another deadly surge, put an end to the pandemic, turn around our economy and our lives. And, by using a mask and the social distancing and the hand hygiene, we're preventing additional spread. And now we would reduce the chance of additional aggressive variants from emerging in the future. So we need to keep this virus under control, and we need to continue with the vaccination effort to get ahead of the pandemic. And so I think paradoxically, it's never been more important to do what we're doing for public health, because we have these variants that may even end up being resistant to the vaccines that we currently have. I know Mr. Lee talked about the hospital bed capacity, and as a healthcare professional in our community, I'm aware that as of Tuesday, just 2 days ago, there were only 12 staffed ICU beds in the entire region, and that includes Spokane area and North Idaho. So again, that hospital capacity is concerning. And I'm going to echo Dr. McLanders that, we're not here for ourselves. We wear other hats in our personal and professional lives, but we're here as a public health board to serve the public health and advocate for our community's health. Our mission is very narrow in scope, and I realize there's many competing interests out there right now. There's the economy, there's educating our children and our college students, and there's public health. But our role is just the public health component of that. So we need to make data-driven decisions. We need to look at our gating, and we just hear the data. We've got 3 counties in substantial risk categories still in the red, and thankfully 2 that have moved into the orange. So again, we need to continue at state of force. We need to continue to follow our legal mandate and the powers that have been granted us through Idaho Code, and that is to do all things to preserve and protect public health. We continue to have our leadership tested, and we can't fail. We can't fail the public health of North Idaho. So I continue to be an advocate for the mask order. Thank you, Tim.
Thank you. Any other comment from any other board member before we vote? All right, hearing no other comments.
Mr. Chairman, just for clarification,
Yes,
are we talking about a 90-day continuation of the mandate?
the motion, as I understood it, was to go until our April board meeting, which is April the 22nd. And then it would be on the agenda again for discussion and a vote.
Well, Mr. Chairman, again, my comment is, this is overstepping. We are seeing a decrease in the infection rates from the coronavirus. We are now getting vaccines coming out that will further decrease that. We are telling the entire population, everyone over the age of 2 must be wearing a mask, when we know that our youth are at very extreme low risk. Those impacted the most are over 65, and they are receiving the vaccine first. I think these are scare tactics, that a misdemeanor offense that won't be enforced by our police departments, by our law enforcement, the sheriff's offices. What sense does this make? We need to advise people, take these steps, they may be helpful, and get vaccinated as quickly as you can. But at the same time, I just object wholeheartedly to a 90-day continuation of this. I would recommend, if anything, we do it for 30 days at a time. But 90 days, just in my opinion, is totally out of bounds.
All right, maybe it's appropriate at this time to call our attention to item B on this document, where it says facial coverings are not required to be worn under the following circumstances: where the individuals are immediate family members or household occupants, children under the age of 2, persons with medical conditions, mental health condition, or disability that prevent them from wearing a face covering. A person is not required to provide documentation demonstrating that the person cannot tolerate wearing a face covering. Persons who are communicating with a person who is deaf and hard of hearing, where the ability to see the mouth is essential for communication. Persons, including on-duty law enforcement officers, for whom wearing a mask covering would create a risk to the person related to their work as determined by local, state, or federal regulators or workplace safety guidelines. Persons who are obtaining a service involving the nose, face, or head for which temporary removal of the face covering is necessary to perform the service. Persons who are eating or drinking at a restaurant or other establishment that offers food or beverage services, so long as they are seated at a table and able to maintain a distance of 6 feet from persons who are not members of the same household or party. This exemption does not apply to entry, exit, or other movement through the facility. Persons incarcerated in a jail or related facility, when necessary to confirm a person's identity, when local, state, or federal law prohibits wearing a face covering or requires removal of a face covering. So there is a long list of people and situations where a mask covering is not required. And I think we need to be reminded of this. I think if people understood this, it would put some of them at least a little bit more at ease. And if there's no other discussion or any comment, we will have a roll call vote, and the secretary will tally. Calling on the roll call, Dr. McLandris, your vote?
I vote yes.
Glenn Daly,
No.
Commissioner Mike Fitzgerald,
Yes.
Commissioner Tim Bertling,
No.
Dr. Alan Banks,
No.
Jay Nelson,
Yes.
okay, and the secretary will give our tally.
It is 3-3, Mr. Chairman.
All right, we have a tie vote, in which case it is the responsibility of the chairman to break a tie vote. The chairman votes yes. The motion passes as presented. Let's take a 10-minute recess, please. We'll try to convene at about 10 minutes after 2.
Inches.
Biggest check I've ever gotten.
Awesome.
Jill, are you ready?
I'm getting there.
You're getting there.
Well, my mouse is.
Okay.
Good. Yeah, we're good to go.
Oh, okay, thank you. We are back in session again. The next item on our agenda is a report from the Executive Council. Glenn Bailey is our trustee, and we'll call on Glenn for his report at this time.
Thank you, Mr. Chairman. During the legislative session that started here in this month, the Executive Council is meeting once a week on Fridays to discuss developments in what legislation and bills have been proposed and what those bills are concerning the health districts. Obviously, with the COVID-19 issues happening in the mandates and the instructions or the guidance from the governor's office have been a huge concern to our state legislators, both the Senate and the representatives. And there's several bills that have been put on the agenda for this legislative session. One of them is from a member of Health District 4, Megan Blanksma, who is a representative and is on the board of directors for Health District 4. Her bill would give the Board of County Commissioners in each county the authority to overrule public health district mandates, or to at least have that capability to overrule what we as the board of directors for the health district come up with. So this, for example, this mandate that we passed today, our boards and county commissioners would have the opportunity to review that and to vote on it. And if they decide no, then that would overrule what we just put together. So at the legislature level, they are not entirely pleased with some of the mandates and things they've seen coming out without more input from the Board of County Commissioners. And a piece of what we've been discussing is to be proactive in changing or amending Idaho County's codes so that we can address some of the concerns of the legislature. One of those would be to amend Idaho Code 39-419 subparagraph and add subparagraph 4, which would change someone in violation of the health district mandate. It would no longer be a misdemeanor, but it would be an infraction. And a misdemeanor is punishable by a fine up to $500, but under what we've got currently, it would be a $300 if you violate any mandate from the public health boards. So this would reduce that down to being an infraction, and it would be a fine of $50, and without including court costs, et cetera, which is much more reasonable, and I think that would probably be something acceptable by the boards of county commissioners. Also, we will be addressing the qualifications for being a member of the health district boards. And they would be saying at least one of our representatives on the health district board would be a county commissioner that is currently serving as a county commissioner. In Bonner County, I was a former county commissioner, and Dr. Banks has not served as on the board of county commissioners. So if this would be implemented, then I would recommend that myself be released and then the board of county commissioners designate who would represent Bonner County as a county commissioner on our board. So those are two of the proposed changes. And I will be meeting tomorrow with the board, the executive council. So I would like, Mr. Chairman, to get a feel from the other board members whether they would support these proposed changes. One, that the penalty for violation be reduced from a misdemeanor down to an infraction with a $50 fine. And the other being that at least one representative on the board be a serving member of the Board of County Commissioners from each county. So if we could get a vote on that so that I can take that information with me tomorrow as I attend this meeting.
Now, are you asking for an actual vote from the board?
I would like to hear from each board member whether they would be in favor of the two proposed changes to Idaho
We
code.
won't, yeah, we wouldn't be able to vote on that at this meeting, but
Well, because it hasn't been
it's not on the
on the
agenda.
agenda. Okay.
Laura?
Mr. Chairman, Glenn, if I might, so my understanding through Mike Payne and is that, it's Representative Blanksma had introduced something and, Senator Vick had introduced something, but he had been working and he met with, he and, Director, Brackow and Director, Maggie, met, with some legislators last week, and came up with some different legislation that, same thing with reducing the penalty to an infraction for not adhering to a county-wide order or mandate. But rather than changing it so that every board member was a county commissioner, that if there was a mandate that was written that affected a whole county, then that mandate would have to be approved by whatever county's
Board of
BOCC,
County Commission.
in order for it to take effect within 10 days, rather than having it sit. So I think that's where we're at. We'll learn more tomorrow.
Right. So anyway, I just wanted to get a feel with what everybody thought so that I can properly represent our board at that meeting. So that's,
Anyone want to comment on that?
I'd be happy to comment, Mr. Chairman.
All right.
It sounds to me like the trustees have put a lot of thought into this, and I'd certainly support their effort to enact the changes that they think would be in the best interest of the public that we serve.
thank you.
Anyone else want to comment?
Mr. Chairman,
Yes.
in reference to what Laura was speaking to, the actual bills that may come out, I certainly think that we as a board of trustees for public health would compromise our ability to weigh out as a board public health issues if our decisions could be supervened by the county commissioners. So I would not be in favor of allowing the county commissioners to supervene or call judgment or decide to negate the recommended actions by any board of trustees in any district of the state of Idaho.
Mr. Chairman, if I could ask a question?
Go ahead.
What is everyone's thoughts on the requirement that at least one representative from our more populous counties be a member, an active member of the Board of County Commissioners? Would you support that?
Well, Glenn, if I could respond to that, I have on more than one occasion approached our county commissioners about the fact that there was no commissioner. And of course, the faces have changed of late in Minnehaha County. But my discussions have always been, they didn't, that they were busy enough with what they had to do, and this is why they would select someone else to serve on the board, because their plate was already full.
Thank you. Okay, I will take that to my discussion tomorrow on the executive board. Thank you.
Mr. Chairman,
Yes.
if I may, Glenn, there was one other issue on the table, and it was with respect to the level of violation and the dollar amount.
Yes.
I think that when you take a look at the vast gamut of things that come before this board, it depends on the severity of the item. In some cases, to have that flexibility would be much more, in other words, at our discretion, would be much more valuable for us as a tool. I think sometimes stepping up to just a misdemeanor for certain items is a little bit steep. So having that flexibility is good. I think how it's written right now is it's requesting just to completely lower it. I would like to see it have some discretionary component to it based on what we feel as a board is necessary to enforce.
Okay, Mike, so you're suggesting a range from an infraction up to a misdemeanor offense for violations?
I'd be more inclined to go with the range, yes.
Thank you.
Mr. Chairman, if I could respond to what Mike said. Can you hear me okay?
Yes, go ahead, Dr. McLanders.
I totally agree with Mike. I think, for example, in the case of this mask mandate, very appropriate to have it lower and have it exercised. In the case of Burlington Northern Railroad, who placed a refueling station over the aquifer, which affects the sole source aquifer, we need to have the power to put it up and be able to say your infraction has larger consequence. I know we're limited in that realm, but I agree with the range.
Thank you.
Okay, that gives you some fodder to feed on. All right, thank you. Does that conclude your report then? All right, let's move on to Laura. And Laura has got some words for us on the, you looked at the strategic plan, I trust. And Laura, what are your comments?
Thank you, Mr. Chairman. Annually, I bring before you a strategic plan. We have a 5-year strategic plan, and that we updated annually to reflect what we think is coming. And Jill, if you would please, I'd like to do a CY20 strat plan review. Jill, is that available? Just kind of highlight. I don't know if you brought that up or not. Yeah, there it is, a strategic plan review. I don't know. There were 2 of them. One was updated with current CPR, the other was not. I guess suffice it to say, our strategic plan, for 2020, we didn't get to a lot of things. And it's the last one, Joe. But what we did get to, our focus areas, are threefold.
Let me get it shared.
Where is it? I don't think it down. There it is, yeah. Okay, there's right there. Great. Sorry, no worries. So in 2020, our focus areas were threefold. The population health focus, a community collaboration focus, and certainly an internal focus on efficiency. Could you scroll down, please? Just some highlights from the year. One of them that we shared with you, Kim Young came in and spoke about it, was our diabetes education accreditation program. One of our goals in 2020 was to become an accredited diabetes education program. And we achieved that despite COVID. Hedgehog implementation, we moved our environmental health programs from I want to say an antiquated, it was decades old tech program to Hedgehog. And we achieved that. We still have some things we're working on, but we are going full Hedgehog. Presentations to our community on PhD services, primarily COVID this year is what we presented on. Our community's hungry to understand COVID, and we've had multiple speaking engagements on COVID. Play, which as you recall is the family program for families with children who have on nutrition and obesity. And we are still working with that program through COVID. We've had 9 participants in our first 2 cohorts. People are very interested in participating in that program. Our formal QI project on communication, that's ongoing. Dental clinics and schools where we have contract hygienists who put sealants on the kiddos that request that service. Our nurse family partnership and parents and teachers families that we've served, 66 and 123. And this was COVID vaccine, community members trained in PPR, and 18 reduced home health patient hospitalizations. That number on the doses of COVID vaccine is incorrect. I didn't catch that error, but that is more like 13,000. So with that, you can place that slide out as our 2020 year in review. I do annually ask the board for input. In last board meeting, I asked you all if there was anything you would like us in particular, any goals, objectives. I always ask my executive staff to work with their teams on coming up with objectives and strategies that would meet those objectives, and what's the measurable outcome that we want to achieve. Again, all of our objectives and strategies are centered around 3 primary areas, which the first is positively impacting public health, the second is collaborating with our community partners, and the third is ensuring organizational efficiency. So beginning on page 27 is our proposed update to our 5-year plan with some of the same objectives with a few tweaks and strategies and some new ones. Happy to answer any questions, but I would appreciate, Mr. Chairman, a vote to approve this so I can take it out of draft form and we can work on some of these objectives and strategies for calendar year 21.
Thank you. I hope you all had a chance to go through this. It's, I think it's a It's a masterful piece of work. And Laura is asking that we approve this document. So I am open for a motion to approve this
I have a
or.
question for Laura, please, before we go to the vote, before we go to the motion. Go ahead, can I ask Laura a question, please?
I'm sorry.
Commissioner Fitzgerald has a question, sir.
Okay, Mike, go ahead with your question.
You bet. Thank you, Mr. Chairman. Laura, when I look through here, there's a couple items that still have 2020 milestones.
Say again?
The four-play program, can you hear me okay there? The four-play program for the 2020. We create the online interactive food program is in November 2020. The hedgehog component of the sewer, the restoral application process is November 2020. And the employer engagement, a couple of those have year 2020. I would recommend that if we approve, make a motion to approve, that we ask that those, if they were not completed during the year, they just reflect 2021 days. It was a pretty busy year with other stuff, and I know a couple probably didn't get done.
Mr. Chairman?
Yes.
Yeah, I apologize that I didn't, we didn't take those up, but yes, we'll go through and correct those.
Having said that, if there's no more questions, I'd be happy to make a motion.
Mr. Chairman,
Yes.
I have a question.
Okay, first off, Mike, was that a motion?
No, I'll make one now if you.
Well,
okay.
just hold off again with your motion if you'd like to make one. We have a question here. Dr. Banks?
Yeah, Laura, on page 31, in the little table that you present, I was looking at item number 2, which was to reduce the number of opioid prescriptions written per 100 population. And I guess I'm just questioning what the goal there is, because if that's kind of you getting between the physician and his patient, isn't it?
Mr. Chairman?
Yes.
So this is our prescription opioid work that we're doing. And we're basing, our national rate for reference is 46.7 prescriptions per 100 people. And the work groups that we have, community work groups, looking at access and prevention and treatment. Our hope is that, downstream, in the long term, the number of prescriptions and education to our providers, the numbers of prescriptions will eventually reduce. I mean, there's all sorts of things going into the opioid epidemic, all sorts of interventions. Like any public health intervention, it's not an immediate reduction, but the goal is that eventually, as we continue to focus on the opioid epidemic, that we'll see some of these indicators showing us that we're not having as many people addicted to opioids. That makes sense.
Well, I understand it's a noble goal, but these are people that are getting the prescriptions from their doctor presumably, and their doctor must have decided that maybe they needed to have that. My understanding is an awful lot of the opioid overdoses are from people that get the drugs illegally.
Mr. Chairman, certainly, we have had some issues in North Idaho where, and that's what the prescription pharmacy monitoring program, where every time somebody writes a prescription for opioids, it's available for another physician or a pharmacist to see. So that if somebody is a chronic user of opioids and is maybe doctor shopping, because that happens, that, if I go to Dr. A and then I go to Dr. B and Dr. C, Dr. B and Dr. C can see that, that I've been to different folks. So the idea of this prescription drug monitoring program is not to tell physicians not to prescribe. I mean, no one would do that unless it was the Board of Pharmacy, because they noticed that this one particular physician, was writing hundreds and hundreds of scripts. And then indeed there would be action taken by the Board of Medicine. So it's one tool in the shed, the prescription monitoring program that we're looking at and hoping to see eventually that, not 46, 47 people per 100 people are getting prescriptions for opioids.
Okay, well, great, that just wasn't clear that this was a prescription monitoring program as opposed to, it didn't say how you were gonna get the numbers down. Maybe I understand your approach now.
I'd be happy to have Kelsey, our program manager for the opioid prescription program, for the opioid prevention program, come do a presentation again about the great work that she's done with our community
Mr. Chair.
members. It looks like Dr. McClanders has a question.
Okay, Dr. McClanders?
Thanks, yeah, I can just help Alan. Every time that we write a prescription for an opioid, it's all electronic on the electronic health record. Every time, then there's a teeny box I can hit, and every time I do, we all do this now, it goes into the drug monitoring program, and I can see exactly what prescriptions have been picked up by this patient, the dates and who wrote the prescription. And then it also monitors how many morphine equivalents these patients are getting. And so we're learning who are getting medicines who are outside of the norm and outside of a normal pain contract. So we have pain contracts with our patients on opioids. They must follow the contract or they are categorically managed differently. So it is an immediate feedback that we get. I just want to let you know that we can actually see what's happening for any patient we write an opioid for. Also benzodiazepines. Thanks.
Great, thanks very much for the clarification, appreciate it.
All right, Mike, are you ready with your motion?
Yes, Mr. Chairman, I'll make a motion that we approve the CY 21 strategic plan with the unconcluded 2020 milestone tasks to be updated to reflect completion of 2021.
All right. You get that, Jill?
There.
Is there a second to Mike's motion?
Second.
All right, thank you. Is there any other discussion before we vote? This represents a lot of work. You've done well. All in favor of approving this with the corrections mentioned, all in favor say aye.
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 Opposed, no? And you have the approval.
Thank you, Mr. Chairman.
Okay, Joe, you're going to talk to us about 410101.
Mr. Chairman, members of the board, thank you. Just a very quick update, especially in view of our new board member. We're the only health district that has a separate IDAPA rule, a statewide rule. All the other districts don't have one, and we have one that has two parts to it. One is the protection of the Rathburn Prairie Aquifer, and the funding for that comes solely from a tax that the Kootenai County residents voted in I believe 2006, or actually it was put in 2007, and so they pay an additional nominal fee of $5 that goes into a fund, and then that funds the whole program for Kootenai County. It's only Kootenai County. The other aspect of it is a set of regulations that cover the institutional control program that's in the Silver Valley, so that's in Kellogg, and also in Kootenai County because it covers both the immediate area where there was a huge amount of mining contamination, in the Silver Valley, but it also covers the downstream portion of that as it affects the watershed into Lake Corwin. So that rule, along with all the other rules in the state, are currently being reviewed because 2 years ago, the legislature chose to not renew them as they've done every year for the very distant past. We are in a unique situation with our rules in that we're the only health district that has one, as I said. So we have cleaned up our rule 2 years ago. The rule that we presented this year to the legislature is, as I expressed earlier, last year, identical to the previous year. It was reviewed and actually went through both committees last year and was approved, but there's an extraordinary process where it has to go through a concurrent resolution from both houses. That process didn't occur, not as a result of anything on Panhandle. It was just a legislative process that never occurred. So where that brings us is we're going before the legislature this year. We had our first committee hearing via Zoom on this last Monday, the 25th, before the Senate Health and Welfare Committee, the same committee that heard it last year. And I'm proud to report that it was approved through that committee. And I believe, Mr. Chairman, if you'll let me indulge you, or if you'll indulge me rather, if we could ask our director, Laura, to quote the chair of that committee. He had some feedback for us in terms of what he thought we were doing right.
Mr. Chairman, thank you. Senator Martin, who is the chair of the committee, stated as after the unanimous vote to approve on 410101, how proud he was of us for solving a local problem locally, and commended the work that we are doing and do some more doing up here.
Having said that, we have a different committee in the House. And last year, that committee was Energy, Environment, and Technology that reviewed it. There was some contention there, however, there was a majority vote in favor of it. This year, that same committee is hearing it again, and some members are new, some are the same. Representative Scott has posed some significant concerns and questions. We've tried to address those in a non-hearing meeting that we conducted via Zoom. The House does not do formal hearings via technology. They require in-person presentations. Having said that, the chair of the committee thanked us for our time. We also had our colleagues with DEQ there. The same issues came up, but essentially where we're at now, as of today, is we're awaiting Chairman Ehart's desires for when she wants us to appear before that committee in person. The plan is that Laura, myself, Eric, and Mary Renberg, our manager in the ICP program, will go down to Boise and explain any questions or address any concerns they have, and we will do that with DEQ. Of course, just want to remind you, one of the options that was discussed was the district giving up a portion or all of the rule to DEQ and DEQ making it a statewide rule. That was certainly not discussed in the Senate. The Senate, as Laura said, thought that the rule belonged locally and was taxed locally and should be addressed locally. So some differences between one house and the other, not uncommon in our state. I just wanted to make sure that you knew that we're awaiting that. And then as soon as we go in and testify, we'll know. I can't predict what will occur, but I can tell you that with the Senate approving it, it would not be what I call a complete fault, which means that the governor may have, this is a lawyer question, but the governor may have the authority to just continue the rule under his existing authority, if that were the case. We don't know yet. We'll report back as soon as we do, and I'm sure Laura will inform the board members via email or other communication, just as soon as we know what the status of that is, but I wanted to update you on that. Mr. Chairman, with your permission, that concludes my comment.
All right, any other questions for Joe on this subject?
Oh, Mr. Chairman, if I may indulge, I'm sorry, one other thing. We have a significant amount of local support. The Kootenai County Board of County Commissioners signed a letter supporting the rule and our continued operation of it, as did the Shoshone County Board of Commissioners. All 6 city governments in Silver Valley have supported it, as well as the cities of Coeur d'Alene, Post Falls, Rathdrum, and Hayden. So, along with significant other community support, including some of the environmental organizations and major corporations such as Buck Knives. So that's all been entered into the record, and we sent all of those letters of support to both houses and the committee members. So I think we're doing as much as we can.
Thank you, Joe. I just wish that Spokane County would recognize what we're doing for them. Thank you. All right, Christine? Here she is, in person. All right, Christine, when you're ready, you have the floor.
Thank you, Mr. Chairman.
Well, let me just mention, as you will notice, board members, Christine is also going to give us a proposed amended budget, and we will be asked to vote on that at the end of her presentation. Go ahead, Christine.
Thank you, Mr. Chairman. As we usually do, we'll take a look at our cash balance.
It's not shared.
Pardon me?
It's not shared yet.
Oh, thank you.
We're only shared through.
Want to drive for me? Yes, please. Yes. Thank you. Thank you.
Where is this guy when I need him?
Yeah. Okay, so we'll take a look at our cash balance. We're reporting for the 6 months ending December 31st. As you're aware, and I'll just mention it for our new board member, our fiscal year runs from July 1st through June 30th, December being 6 months. We've ended December with a balance of $3,684,000. We still have an increase over the June ending balance of $295,000. Before board committed funds and program restricted funds, we have 3.55 months in reserves. Once we remove those board committed funds and program restricted funds, which are a total of about $650,000, we have 2.92 months in reserves. Any questions before we move to the budget to actual, Mr. Chairman? Yes. The other thing I should mention, we are a cash basis entity, so everything is reported cash basis versus accrual or modified accrual. Although this does include accounts receivable, which is backed out to get to the ending cash balance. So total fees and contracts were under budget by $195,000, and this is mainly related to home health and clinical due to the fact that we didn't have the volume because of COVID. We weren't able to see the clients. Our grants are currently over budget due to the fact that we've billed the CARES Act for COVID reimbursements. That would be included in the total amount of the 194. So overall, we are under budget in revenues by $304,000.
Question.
Yes.
Mr. Chairman, if I may.
Yes.
So where is the CARES, is there a category somewhere in the documents we were sent that?
In your board packet,
No.
you have the line item detail of the budget actual, which you typically see. And grants here, we have a total of $3,021,000 that's been billed fiscal year to date. And that is currently showing $162,000 over budget, and that's because it does include CARES. You don't have anything specific to COVID itself as far as revenue and expense.
Great, thank you.
Personnel expenditures are currently over budget by $60,500, and that's related to COVID. And we'll be discussing this in more detail when we get to the request for additional spending authority. Operating expense is currently under budget by $392,000. Capital expenditures under budget by $116,000. Trustee payments over budget by $44,000. Remember, we made the payment, I believe it was about $36,000 where we paid out the governor's trust fund. That was not included in the original budget. So total expenditures, we were under budget by $403,000. So if we look at total excess for the 6 months to date, we have an excess of $551,000, adjusting for accounts receivable. We add that to the beginning cash balance, which brings us back to the $3.684 million. Mr. Chairman, any questions?
Questions? It looks good to me, except for it doesn't.
So this is not a total budget revision as we've done in the past. This is to include COVID expenditures in our current budget. Basically, it's a request for additional spending authority. A number of meetings ago, I had explained that in the STAR system, if we exceed our current budget, which is the spending authority in the system, if we exceed that, we can't process payments. So this is a request to get the budget expenditures included in the fiscal year 21 budget so that we can continue to actively respond to the COVID event. So column E shows the total fiscal year 21 budget. The original budget was $12,400,000. We estimate that the COVID response through June 30th will be $3,023,568. In that $3,780,000 was already budgeted, because at the beginning of the event, we had a number of current employees already working on the COVID event. So they were already included in the original budget amount. So I backed those out. So what we're requesting is an increase in personnel of $1,600,000, an increase in operating expense of $600,000, capital expenditures of $11,000, for total expenditures of $2,243,000. So we anticipate that we'll be able to fully bill those expenditures. We've adjusted for that, let me look here. This $530,000 is the employee, I'm stumbling here, excuse me. This $780,000, which was previously budgeted, I've reduced the revenues by the same amount, because we can assume that in the original budget, they would have been included either in contract revenue or in fees, clinical fees. So once that's taken into account, then of course our total income is going to be our balancing figure of $2,243,000, bringing the revised budget to $14,653,000, an 18% increase.
Question, Mr. Chairman?
Question?
Yeah, so Christine, so that $2.243 million, that's coming from CARES?
That's going to be a combination of funding sources. It's going to be CARES. CARES ended 12/30. We were actively billing towards that up until it ended 12/30. And then we have the ELC grant, which is the Enhanced Laboratory Capacity Grant. And that is, I believe, at about 3.6 million that we have. We also have FEMA that we can look to. We received a vaccination readiness grant of only $53,000. We anticipate a amendment to that of about 84. And we do anticipate another amendment to the ELC grant in about the amount of 1.8 million. And there's also discussion that there will be vaccine funding coming through.
I have a question, Mr. Chairman.
Yes, Dr. McClanders, go ahead.
In projecting additional operations expenses, this is through June, through this fiscal year, right?
That
Are
is
you projecting at the same current rate of needed staff, or are you projecting increasing, based upon vaccination rollout and other factors? How are you predicting the next 5 months? Steady state or increasing?
That's an excellent question. It's been challenging to anticipate the financial needs of the event. For this personnel component, what I did is I anticipated out through June 30th based on the individuals assigned FTEs. I did add 3 individuals to the personnel budget based on the potential that we may need additional vaccinators. So there are 3 additional FTEs in the personnel component of it. Now that may change based on how it rolls out and the public response. Now, as far as overhead, that's interesting. I took the actual expenses, and knowing that we were going to have the vaccine rollout, I either doubled or increased the multiplier by more, because I knew that we would have more rental expense. For example, the fairgrounds. We increased we increased the facility needs at the fairgrounds from the building that we were using for the testing site to an additional 2 buildings for the vaccination sites. And if I recall correctly, I have it noted here, the vaccination sites are costing about $5,300 a week. And the testing facility is costing about $5,000. So I did take those factors into account. So to the best of the information that we have available now, I did try to estimate those costs into the future.
Question, Mr. Chairman?
Yes.
This is for Laura, I think. So we don't do testing here at this facility or vaccinations here? Why? We're doing them at the fairground instead?
Mr. Chairman? Correct. On the testing, we initially, Kootenai Health stepped up and was doing the bulk of the testing throughout the 5 border counties. Certainly there was some testing being done initially by Bonner General, and then eventually Heritage Health started doing some testing in Shoshone County. In July, I believe it was, Kootenai Health asked for some help because they were overwhelmed with the testing. So in conjunction with Northwest Specialty Hospital, we set up a testing site at the fairgrounds. We didn't want potentially positive COVID patients coming to this facility. And we have a drive-through site that is really, which is kind of the gold standard in testing, where someone can drive their car through and get the PCR test. On the vaccine portion of it, when we were early January, when we first started vaccinating and had yet secured the site, and there was such demand for the vaccine, we did set up a vaccine site here in this room, as well as in our Bonner County facility, which they were all very well received. It overwhelmed the facilities, frankly, and we shortly thereafter set up or arranged the testing site at the Kootenai County Fairgrounds. And we are doing a second dose site Wednesday, Thursday, and Friday this week at the Bonner County Fairgrounds. The limiting factor is vaccine. Were we to have more vaccine and the demand is what it is right now, we could set up, 4 days a week testing at the fairgrounds. As it is with our health district's allocation of a vaccine, supposing it's 2,800, it's about 300 doses a week. I would think that in the future, we're gonna see much more vaccine. We are very encouraged that we've got providers that are willing to move clinics. Kootenai Health will be, they're receiving the bulk of the vaccine from Kootenai County. And they'll be setting up clinics next week, as will we, as will Northwest Specialty, and our partners in the other counties. Does that answer your question?
Kind of, yeah. I just wondered why it wasn't being done here, and I think you touched on that, which was had too many people and you didn't want to bring potentially sick people here to the health district, correct?
As far as, yes, as far as the testing, right? Because the majority of folks that we test are symptomatic.
Great, thank you.
And then here at this facility, limited in space too.
Certainly when we had 300 people coming in a day for the vaccine, very limited space in trying to maintain distance.
Okay, Christine?
Are there any other questions related to the proposed increase to the budget?
Mr. Chairman,
Yes.
my question is, so you anticipate that the COVID grants, et cetera, will be bringing in $3,230,568. Yeah, the pink line, the bottom line there.
Yes, we anticipate that we should be able to recover full costs, although there is an exception. And the exception is the CARES Act. It will not cover allocations such as the STARS expense, the insurance expense. And those are allocated out to all programs based on a percentage of hours. We would have had those costs anyway, but they will not be reimbursed by CARES. So we do know that that will be district funds.
Okay. And then you can get some of that funding, 780,168 out of previously budgeted. So the total that you need us, the spending authority you need us to approve would be the $2,243,400.
That is correct.
Okay.
Do we need a motion for that, Mr. Chairman?
To approve this amended budget, yes, we need a motion.
You want to?
Okay, Mr. Chairman, based on the information and the discussion, I move that we approve spending authority in the amount of $2,243,400, which would be an 18% increase for the FY21 budget.
And Dr. Banks, I can hear him second it.
I'll second that motion, Mr. Chairman.
I thought that's what you were going to do. Any other discussion on this? Is there any chance there'll still be another amended budget before the end of the fiscal year?
It's entirely possible. Yes.
Okay. All right, we have this motion with a second. All in favor of this amended budget, say aye.
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 Opposed, no. So there you have it. Who knows what will happen in the next 6 months?
Thank you, Mr. Chairman.
Could you stop the share?
I'm sorry.
No, we're.
Well, the director is waiting to give her report. Let's see what she has to say.
Thank you, Mr. Chairman. Has Susan Buxton joined us? A few things, and I have asked, and Susan Buxton, who is the administrator for the Idaho Division of Human Resources, has joined us. Welcome, Susan. And I asked Susan to join us to have her, I guess, explain to you why she's backing what my proposal is. Let me start with a memo that came from the governor on December 30th of 2020. He directed that a certain number of classifications that affected 29 of our employees be granted a 2% increase, and then with retroactive pay back to the beginning of FY21. So they said that affected 29 of our employees, primarily our CSRs, our AAs, RNs, RN managers, leaving the rest of our employees without that 2%. As you recall, the 2% increase, although budgeted in our FY 21 budget was held by the governor. So in speaking with Susan, and in looking what is happening with our compression and retention of these tenured employees, when I hire an employee now, I pretty much have to bring them in at a rate very similar to, or just slightly below somebody that's been here for maybe 5-10 years. So I really do have a compression issue, and it's just getting worse. So what I'm proposing, and I chatted with Susan at length about this, is that for employees that have been here over 1 year, based on how long they've been here, in increments of 1 to 3 years, 3 to 10, or 10 years plus, and also based on their performance, that they receive an increase for a total of, it would cost us a total of $66,000. This is for only classified employees. I have 2 non-classified employees as well, and I would propose that I give them bonuses. The work they've done, those are our 2 division administrators, during this COVID response has been extraordinary. They've been working sometimes 7 days a week with no overtime, just 9-10-hour days. So I would ask you to consider allowing me to grant employee retention compression adjustment plan for a total of $66,191 plus a total $2,000 bonus for each of my administrators for a total of $70,191. Ms. Buxton, do you want to weigh in here?
Director Whalen, thank you very much for inviting me. Everyone, I appreciate the time, and I hope that I got on the call fast enough for you. I know how busy you are, and I thank all of you for your civic, for doing what you do, because it's very difficult. We can't run our government without those folks like you that volunteer to be on the boards across the state. My name is Susan Buxton. I am the administrator for the Division of Resources, which is part of the Executive Office of the Governor. So it's basically the centralized HR for our 25,000 state employees. And part of that is looking at, what do we look at the CEC, which is the cost of, it's the cost of the cost of living, not the cost of labor. Where are we as to market with regarding higher total compensation for employees across the state? And looking at that, the CEC has several components. Last year, one of the components was a 2% merit CEC. And if you're looking at what happened after, in March, when actually in February, when the legislature approved the CEC, the 2% merit increase, as well as some other components, everything was looking great. We had a 2.4% unemployment rate, and certainly the revenues were looking to meet all the projections. So let's look at April. By April, we were 11% plus unemployment, and in our worst case scenario, we're starting to look at a potential reduction in revenues by potentially being underwater by potentially $700 million. So in looking at that, we felt like it would be safer to not implement the CEC while we look to see what the revenues would do for the rest of COVID, and make sure that we would not want to give employees a raise and then have to take it back. And that was one of the things that the Division of Financial Management decided in consultation with the Division of Human Resources. So in doing that, that CEC was part of a freeze on hiring, a hiring freeze, and there was also a freeze on merit or any raises. As you know, the health districts, that hiring freeze was not applied to health districts, so they're able to make sure that we could hire people as needed across the state to address the pandemic. And when Director Whalen was talking about the targeted employees, that was a little bit different, but it's not quite the same as the 2% across the board CEC. But it was a 2% increase for certain classifications in all agencies, so it wasn't just targeted to yours. but it was for all agencies, 20 targeted positions. Those are positions where they were, we looked at all classifications, we have over 1,000 classifications we look at. Those were hard to fill, hard to retain positions, and that were likely, they were already under market further than the 10% that we see from an overall perspective of being under market. So that 2%, we held that back too, because we wanted to make sure we had money to retain as many employees as we could. And I think it's important for you to all know that statewide, we did not lay off employees. We had fewer layoffs this year than we did even the year before. As far as furloughs, the furloughs were only felt by higher ed. And there were no other furloughs. And one of the reasons for that is that our state employees are essential. And also we felt like it would be more important to state employees in every community and every part of our state, that they be part of our economy and trying to keep them working and then serving the public. So when we're looking at that 2% for those targeted employees, that was released again on the 29th of December, and so we're properly talked about that. What we're really talking about today is an October 8th memo from the governor where the hiring freeze and the pay increase freeze was lifted, because at that point we felt pretty comfortable with the revenue projections and felt like we could use part of that CEC for hard to fill, hard to retain positions based on merit. So you had to have people that were performing as meritoriously, and that they were trying to target positions that are hard to fill and hard to retain. So one of the things that we looked at is we do have compression issues and compression needs that I'm hiring somebody at the same level as somebody who's been here for 4 or 5 years, and it really is a problem for retention. It's a problem for morale, and so we're looking at those agencies who could give us a proposal to do that. And the Panhandle Health District was able to do that, did a nice job of it. So it was approved by the Division of Human Resources and the Division of Financial Management. So with that, I am happy to stand for questions for you, because this is one of the few times that we're able to really target something like depression with these types of funds. And so both Alex Adams and I felt that it was important to try and look at those things, because I did ask the governor, and he agreed in his budget to recommend another 2% CEC for fiscal year 22 to be incorporated into everyone's salaries on July 1st of 2021. So my point with that is that we felt like this was a way to try and get ahead of some of these compression issues and make it separation that will help in the future for retention, especially of our valued employees. So with that, I'll answer questions from you, Madam Director, or the board.
Susan, this is Marlon Thompson. I have a question.
Go ahead.
Does this bonus plan include the director also?
Mr. Chairman?
Mr. Thompson, I think I heard you say Thompson, is that correct?
Yes.
Mr. Thompson, it does not. The director's salary is something that is recommended by the board separately from something like this, and you can do it at any time, and then that goes to the government.
Thank you. I just wanted to hear that from you.
Okay.
Okay.
Yes.
Mr. Chairman, I have a question.
Gwen Bailey?
Susan, so the source of this funds will be from the state of Idaho to the health districts, is that correct?
Mr. Chairman, I think I can answer that. So when we did our FY21 budget, we budgeted 2%. So that was, the money was already in there. And part of the reason our salary dollars are not as over budget as they should be is because we had those monies in there. So there was over $150,000 in our original budget for this 2%. And what I'm asking for is $70,000 to cover this for the the remainder of the fiscal year. And just to be clear, it wouldn't, the folks that have already gotten the 2%, where they fall on the matrix, they won't get over where they fall on the matrix inclusive of the 2% they've already got,
Okay,
those 29.
Mr. Chairman, thank you, Laura. So my question is, what would be the source of those funds that you are requesting?
Well, it's where our funds come from, the contracts, the grants, the fees. It's where all of our funds come from. I mean, how we originally budgeted, based on our, part of it is covered by the state appropriation, very, very small percentage. And certainly, the district and the state funds, the contracts, the fees, where all of our funds come from.
Okay, so your big pot
Right,
is where, so you're asking us to approve a total of
$70,191.
$1,191. Okay, thank you.
Any other questions?
Not if you have any questions, but it is an action item, so.
She wants to stay on while we vote. She needs to go back to whatever. All right, this takes a vote from this board, and you've heard the details. So we're voting in on this amount, $70,191. A motion to approve this?
Mr. Chairman, I make a motion that we approve the compression and retention plan in the amount of $70,191.
Is there a second?
Mr. Chairman, I'll second the motion.
All right, I hear a second, I think, from Mike.
Yes, Mr. Chairman.
All right, any other discussion on the motion before we vote? Hearing no discussion, all in favor of approving this amount, indicate by saying aye.
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 And opposed, no. And the motion passes. Susan, thank you for taking time out of your busy day to explain some of these details to us. Appreciate that.
Mr. Chairman.
Mr. Chairman, thank you for giving me the time, and again, I thank all of you for your public service and,
All right, Laura has some final words.
Thank you very much, Susan, for your support and for DFN's support. I just want to be clear that the effective date will be our next, our next pay period. We'll just be going with it. So thank you. The staff will greatly appreciate this today. The last thing I have for you is our JFAC presentation. The public health districts are slated for 15 February. I do understand that that is a committee that will accept Zoom. So we'll be zooming in on 15 February. Director Rakow drew the straw and will be presenting for us, the 7 of us, but we'll all be on. It is late in the JFAC portion of the year. One of the, I think the last week of JFAC presentations. So I look forward to that. Mr. Chairman, that completes my report.
All right, thank you, Laura, thank you, all of you, for participating in a active, busy meeting. Anything else to come before this board at this time? Hearing nothing, our next regular scheduled meeting will be March the 25th, 2021. And at this point, we are adjourned.